The re-tear rate after meniscus repair is around 15 to 20%. That's roughly 1 in 5. So how do we bring that number down? That's what this week's paper addresses. It's the Sunday paper roundup, where I read the papers so you don't have to. This week's paper is from Kester, Biological Augmentation Strategies and Meniscus Repair, a Delphi study. Full disclosure, I know several of the authors. Tim Spalding's my colleague and my partner at Cleveland Clinic London, and then alongside Ian Murray, Kira Stevenson, James Robinson and Rob Leprade. Good people doing excellent work for our community and our patients. But let's analyse the science. This was an international Delphi consensus study, 33 selected global experts, 3 rounds, a 100% response rate and 66 final consensus statements. This is level 5 evidence, expert consensus, it's not outcome data. But in biologics, where the evidence is low level and fragmented, structured consensus is useful. The key conceptual point, biological augmentation means modifying the healing environment, not regenerating tissue. They explicitly caution against casually using the terms stem cells unless true in vivo differentiation is proven, and that's important. It's an important ethical and scientific position and intellectually rigorous. So what do they end up recommending? What do they actually support? Simple, low-cost biological stimulation in selected higher-risk tears with trephination, marrow-venting and fibrin clot, particularly in radial, complex and horizontal cleavage tears. They did not support the routine use of PRP, BMAP or stem cell-based therapies. The evidence was considered inconclusive and inconsistently reported. Cell-based therapies should remain within research settings for now, and that is a measured conclusion. They emphasized routine MRI in asymptomatic patients is not required, MRI can overcall failure, imaging must be interpreted along clinical findings, and clinical success is symptom resolution and function. They also recommended a minimum 24-month follow-up, which is interesting because in routine clinical practice, it's usually 3 to 6 months within the confines of most health systems. They also outlined ethical guardrails. There was unanimous agreement that biologics are vulnerable to direct-to-consumer marketing, exaggerated claims, and poor transparency. And that's a powerful inclusion. This paper doesn't just discuss technique, it discusses responsibility. Let's dive deeper for a critical analysis and see where I can hammer Spalding. Well, the strengths were a rigorous Delphi methodology, accord compliant, predefined consensus thresholds, a 100% response rate, international representation, and clear terminology clarification. For consensus work, this is robustly done. Bugger. What about limitations? Well, it's level 5 evidence. It's expert opinion and not evidence of the actual efficacy. It was a predominantly male panel, orthopedic surgeon heavy representation, limited physiotherapy input, and no tear-specific head-to-head comparisons. Consensus provides structure, but it does not provide superiority. It's not proof. However, it does bring order to a chaotic space. What does this mean clinically? It validates something many experienced knee surgeons already practice: selective, low-cost biological stimulation in high-risk tear patterns. It does not support routine escalation to expensive injectables, but it reinforces tear-specific decision-making, alignment assessment, standardized outcome reporting, and ethical patient counseling. In a biologics-heavy era, that clarity is important. So what's my verdict? Should you ignore it? Should you be aware of it? Should you consider it? Or should you go right ahead and change your practice? Well, I think you should consider it and practice accordingly. Use simple biologic stimulation techniques where appropriate and avoid routine escalation to expensive injectables outside of trials. That's not revolutionary, but it brings clarity, and clarity improves practice. Stay tuned for next Sunday's paper roundup. I'll keep breaking down the evidence as it lands.